Today we're talking about Achilles tendinitis, or what it might be instead of that. So check out a video where I cover, actually it's two separate videos where I cover the entire tendinopathy umbrella. So that goes through tendinitis, reactive tendinopathy, the whole gambit of tendon stuff. So first of all, we could say it can be that. We had a patient recently that came in with a diagnosis of Achilles tendinitis. They got put in a boot, was immobilized for a long time, went through physical therapy. And I just simply asked, what did you have? You know, redness, swelling, heat, things like that going on? No, not at all. Well, that rules out an inflammatory component, which you can pretty much rule out tendinitis. Doesn't mean nothing's going on with the tendon, but what else could it be if we're starting to think maybe a little more outside the box? The first thing is lumbar spine referral pain. So if we look at in particular, an article from the Journal of Manual Manipulative Therapy from 2019, they say around 29% of pain around the ankle and foot can be generated from the lumbar spine primarily. A lot of the times when we're looking at lumbar spine derangements that are causing referred pain or radicular symptomatology, we can go after something like in-range loading, in particular in lumbar extension. So you can check out a video on lumbar extension. Obviously, that's just a lot of people respond to different directions, whether that's flexion, lateralization, maybe they don't have a directional preference at all. It's thought that with low back pain in general, around 60-70% of patients with low back pain have a directional preference, which means that their pain will alleviate or referred pain will centralize, move from further out to closer in. When they move it, repeated in range. So that's one thing, that it could be referred pain. You could have legitimate radiculopathy. I don't think you're going to walk into somebody's office thinking you have Achilles tendonitis if that's the case. You're probably going to have a radicular pattern that warrants not just Achilles pain. Me as a clinician, I've missed let's say pain around the Achilles that was generated primarily by the lumbar spine by being misled by the patient's history, what they told me, previous foot and ankle issues. So as a clinician, it always pays to rule that out. So as a patient or somebody dealing with this, it sometimes pays to rule it out. So go check out that video. I always encourage people to seek out a professional in the area for a full assessment, so you don't waste time. It may cost you a little bit of money, but that's an investment, because what you will save in time and pain, you'll make it up. The next thing that it could be, which we've talked about in a bunch of different videos, would be some sort of peripheral nerve entrapment or cutaneous nerve irritation. And the patient I was talking about that got put in the boot, that's what the ended up being, is kind of concomitant peripheral nerve entrapment, where the tibial nerve had a neurodynamic issue, which is one thing we'll talk about here in a second. It was showing up with these nerves, the lateral medial calcaneal nerves were being irritated. So this patient said, hey, my heel really hurts just on the sides where the bone is, not even kind of what's called the enthesis or the insertion of the Achilles. It was kind of outside of that area, but it was right where these two nerves, are very close to the skin, as a cutaneous nerve would be, because it's primarily responsible for sensation of the skin. So on palpation, this patient had pain, but not many other things. Jumping, not really running, wasn't that bad either. And then we found that out through, messing around with some treatment inputs. So things like cupping, where we can use, I always use this terrible analogy of if a nerve is an al dente piece of spaghetti and the superficial fascia and skin is saran wrap, we can lift that saran wrap up via cup or tape or voodoo floss. Even though voodoo floss is technically compression, it's still kind of moving the fascia around in a novel way, and move that around, have novel input to that peripheral nerve, and then maybe have change to pain, which may or may not have changes up and downstream. So that's one way to test that. You could also vigorously rub, not heavy-handed, but lightly over this area, creating almost like what would we call a stecco effect, creating a lot of friction, heating up the superficial fascia, and not necessarily maybe rubbing where it hurts, maybe beside it. So again, if that al dente piece of spaghetti is here, that nerve that's irritated, we rub on both sides to have some sort of myofascial effect to offload irritation. You can have a neurodynamic component, which is a nerve further up the chain is being irritated by constriction, some sort of myofascial entrapment. It could be even further up into the spine. A lot of times there's two sites of entrapment. But as that nerve is trying to move through the neuronal sheath and the surrounding tissue, it's having a hard time and it's getting irritated, and then you can have peripheral symptoms due to aberrant mechanics, overuse, malfitting footwear, whatever it is, can show up with pain around the heel. And another way to play around with, well, is it actually being generated by my Achilles tendon, by my low back, or is it this peripheral nerve issue? Would be something like kinesio tape or rock tape. And I always say that tape like that is basically like a cup dialed down 100 times. So it's supposed to gently lift the skin to then create kind of a novel input of movement of the skin against the tape throughout the day as you wear it, which then can have novel input that alters the sensitization or the irritation of that peripheral nerve. So that'd be a good way to diagnostically test it, but also maybe, I'm air quoting, treat it in terms of alleviating pain. The last big one would be a trigger point. So if we look at work by Travell and Simons, classic referral patterns, and in this case, the soleus and the posterior tibialis are the ones that ring true, because as you can see by these giant red patterns that are coming off these X's, which are trigger points, which you can go listen to a cool interview I did with Steve Capobianco on trigger points. We talk about peripheral nerve sensitization, trigger points and trigger point referral, so a lot of stuff we're talking about today. But if you have a referral or referred pain coming from a trigger point, as a patient, the best way to kind of test that is probably to like foam roll or use a lacrosse ball, but work that tissue and see if you get some sort of referred pain. So I don't think it's maybe the best option to smash, your Achilles tendon. And I know, back in the day, people were using, the handles of a kettlebell and smashing their Achilles. Like, I don't know if that stuff's the greatest idea in the world. So if we can create some sort of referral by kind of working on the tissue upstream of the pain, and you're like, man, I feel that in my Achilles, and I'm working on my soleus or my gastroc or my posterior tib. Well, ding, ding, ding. Now, again, an assessment by a practitioner, this is going to be a lot easier to suss out with hands-on palpation, orthopedic testing, making sure nothing is going on that warrants further workup. One thing I would suggest against here is a lot of people, instead of using a foam roller, will now use like a hypervolt or a Theragun. So anywhere, in particular, if we think there's like a trigger point or a sensitized nerve, it's not the best idea to take a percussion gun and go basically perpendicular to that tissue if we're talking muscle. You want to kind of go tangential to it, work along it, like we said, the al dente spaghetti, work along it, have some sort of myofascial input that's not directly where the pain's being generated. If you have a nerve, you definitely don't want to percuss that nerve, because if we have a sensitive cutaneous nerve that's very close to the surface, you can imagine that that neurologic structure is not going to take basically getting jackhammered very well. And the very last option that I can think of, outside of it being a legitimate tendon issue, even if it's not tendinitis, would be some sort of bony issue around the heel. And again, your calcaneus is a very strong bone, and even though that's the case, some people will get a stress reaction or stress fracture in there sometimes. Obviously, you can have an acute fracture if you want to jump off a couple-story building. Believe it or not, besides imaging, the most specific test for a calcaneal stress reaction fracture is what's called a squeeze test from an orthopedic standpoint. Squeezing on both sides, medial and lateral of the heel, eliciting pain. Now, a lot of things are going to elicit pain in the heel besides a stress fracture. Interesting note here is a patient or somebody that's not a practitioner out there, just like you can't tickle yourself, it's hard to elicit the same pain responses with you doing a provocation test on yourself. So you may not have pain and then somebody else does it and you do have pain. Just realize you have different feedback loops when you do something versus somebody else. So that can alter input and output. I hope that helps somebody out there that's been dealing with heel pain that maybe got misdiagnosed, been banging their head against the wall, of some ideas to work with. But as I always say, I suggest finding a good practitioner in your area to get a full assessment, which will make your life a heck of a lot easier, and you'll probably find out some other things that you could work on that may have been contributing to this. Let me know if you have any questions, and see you next time.